Okay, bye.
Bye.
Θα συνεχίσουμε με τον κύριο Κοσκινά, ο οποίος, γεια σου Κώστα, από τη Λευκάδα.
Γεια σας, ευχαριστώ πολύ.
Πες μας τι καιρό έχει εκεί πέρα που είσαι.
Σαφώς χειρότερος από τον καιρό που έχετε εσείς, είμαι σίγουρος.
Θα σου στείλω φωτογραφία τώρα από τη θάλασσα σε λίγο.
Ωραία, για να ζηλεύω. Ευχαριστώ πολύ.
Δεν ξέρω, ο κύριος Storey αποσυνδέθηκε. He's still on. Θες να δώσεις τη συνέντευξη?
We can do it in English. I was prepared for English, honestly. So it's fine for me. No
Sorry, Rob. Sorry, Rob, for that. Okay.
No, please, Greek will be fine.
No. We are. This session is in English, so Kostas, who is a great speaker and a good friend, he's going to give his lecture in English so that you can probably intervene. So his talk is about the effect of LDL lowering therapies of coronary plaques. Kostas Koskinas is working in Switzerland, in Bern, if I assume, yes. And he has he's an excellent interventional cardiologist, and he has some major concerns in research considering LDL therapies. He's one of the first authors of the EVOPAC study recently published, and we hope that Kostas will give us the emerging data concerning imaging of coronary plaques. And Costa, you have 20-25 minutes, and we are waiting for
Excellent.
you. Thank you.
So thank you very much. Just please a confirmation that you can see my screen, which I just shared. Can you see my slides?
Yes, you're okay. Yes.
Excellent. So indeed, thank you very much for the invitation and introduction. I'm going to talk about the data on intracoronary imaging and the effect of LDL lowering therapies on coronary plaque. So in the first part, let us just summarize what we know, what are the indications, and what is the value of intracoronary imaging. We know, of course, that coronary angiography is the gold standard to visualize the coronary anatomy and detect coronary plaque. But it has well-known limitations because it's basically a luminography. It doesn't show the plaque itself, and also the ability to detect plaque is limited sometimes by the presence of vascular remodeling, which can lead to underestimation of coronary atherosclerosis. More than 30 years ago, Glakov first published this historical report on remodeling, and we know that we may well have advanced plaque, which grows in the context of positive remodeling, which then preserves the lumen size, which means that luminography alone, angiography alone, can underestimate the presence of coronary plaque. And we also know that we may have some regions in the coronary tree which may only show minor irregularities in angiography, but then again, they may hide some major plaque which can be detected by means of intracoronary catheter-based imaging. We may also have similar sites also in the same artery, which look similar on angiography, but may differ substantially in terms of IVUS imaging. In terms of the so-called vulnerable plaque, there's been a lot of discussion about this concept. We know that the lesions that are causing these acute thrombotic events, either through plaque rupture or less frequently through plaque erosion, are well characterized in autopsy studies. And by means of intracoronary imaging, we also know the hallmarks, the characteristics of these vulnerable plaques that can cause these acute and life-threatening events. And typically, high-risk plaques have large lipid cores, thin fibrous caps, and high degree of inflammation. The three modalities, IVUS, OCT, and NIRS, which we can use also clinically in the cath lab to detect plaques, have differing value in terms of detecting different indices and hallmarks of plaque vulnerability. And we see here that IVUS, for example, is excellent for quantifying plaque burden. OCT is the best method to directly assess cap thickness and also identify macrophages. And NIRS is the best method to look at lipids and also measure the amount of lipids within a certain coronary plaque. and these modalities clearly are superior to either angiography alone or also non-invasive CT-based assessment of coronary plaques. And there has been extensive validation also for all three of these modalities in terms of characterizing plaque morphology and plaque composition. This has been shown, for example, for IVUS VH, also for OCT against histology, either in animal models or also in autopsy studies in humans. And finally, also for NIRS, we do have strong validation versus histology for detection of lipid-rich coronary plaques. Importantly, it's not about theoretical assessment of plaques, but it also has to do with the clinical consequences of the sequelae of these plaques. And we know in the past years that detecting plaques with presumed high-risk characteristics can actually predict future subsequent clinical outcomes. This was shown first by means of IVUS VH in the PROSPECT study 10 years ago. And this study showed that TICFAs, as identified by IVUS VH, which are thin cap fibroatheromas, have a much greater likelihood of resulting in a subsequent major cardiovascular event. The same holds true also for NIRS, and recently we had the publication of the lipid-rich plaque, where both on a patient level and on a plaque level, the study asked the question if identification of lipid-rich lesions can can predict future outcomes. And indeed, this was also a positive study, and we see that on a patient level, detection of a lipid-rich plaque carries an almost twofold high risk of subsequent MACE, whereas on a plaque level, the detection of such a plaque is associated with an almost fourfold high risk of subsequent of future MACE, of a future major cardiovascular event. And finally, for OCT, the CLIMA study was published about 2 years ago, and it also confirmed in more than 1,000 patients with a non-significant LAD plaque that detection of some regions with high-risk characteristics in terms of OCT can also identify those patients who are at high risk of subsequent events within only 1 year of follow-up. And here's a summary of what we know about the positive and negative predictive value of catheter-based, so invasive, as well as non-invasive modalities, which is IVUS, OCT, and NIRS versus CT angiography for prediction of subsequent events. We see that these modalities have rather limited positive predictive value, but they have a very high and excellent negative predictive value, which in simple words means that if you don't see such a lesion with presumed high-risk characteristics, then it is extremely unlikely that our patient will suffer an acute event or a major event in the next years. So moving to the main part of today's topic, what has intracoronary imaging shown in terms of assessing the effects of LDL lowering therapies? There have been serial studies, first of all, serial angiographic studies in patients with established coronary disease, and we know that CAD is actually a progressive disease. So under the effect of adverse risk factors, we know that the degree of stenosis tends to increase over time, and conversely, of course, lumen diameter tends to decrease over time. And we also know from IVUS in humans as well as in animal models, as we did, for example, in a pig-like model of disease where we had the possibility to perform IVUS at 5 consecutive time points. We know that indeed atherosclerosis is a progressive disease which tends to build up over time. So the question is it possible to have regression of established disease in humans? Is it possible to stop or even have a reduction of atherosclerosis in human patients? And first of all, let us look at the evidence that we have with statins, which is of course the gold standard for lowering LDL, for lowering atherogenic lipids. We know that plaque regression is indeed possible, at least as it has been shown in serial IVUS studies. We know from the first study that was able to show this, which was the Storey study, that treating patients with high doses of statins can indeed reduce the area of plaque, which is shown here in yellow color. And this is, of course, a characteristic of a patient who had a marked reduction of plaque within less than 2 years of follow-up under the treatment of high-dose statin. Here's a summary of serial IVO studies with statins showing either no progression, that is stabilization of plaque, which was the first study, the reversal study on the left side of the slide. And then we also have several IVO studies that have shown regression of plaque. And these were the Asteroid trial, the Saturn trial, the IBIS-4 study, and more recently, the PRECISE study, which was the only of these studies that did not use only statin, but also combination with ezetimibe. And here, let us take a look at the characteristics of these studies. What was the profile of patients and what was the effect that was detected? And we can see that the major characteristics of all these studies was, first of all, the use of really the highest doses of the most effective statins, atorvastatin or rosuvastatin. And as I mentioned in the PRECISE IVO study, we had the combination actually of atorvastatin plus ezetimibe. And second, notably, the regression was observed only when on-treatment LDL was very low, that is on average below 70 milligrams per deciliter or 1.8 millimoles per liter, which was, of course, also the goal, the treatment goal in the previous, the 2016 lipid guidelines. And here, a very interesting figure showing exactly the relation between the on-treatment LDL and the change of percent atheroma volume, which is the typical primary outcome in these serial IVO studies. And we see in green color that if the LDL levels are 80 or higher, then we have no regression. But if we focus on those with blue color, if we can achieve even lower LDL levels, so 70 or even lower, then indeed we have significant, modest, but significant reduction of percent atheroma volume as assessed by means of IVOs. Plaque burden is important. It's a very important also predictor of subsequent outcomes, but also plaque composition has a critical role because, as I mentioned, those plaques that especially trigger the acute events, the acute atherothrombotic events, have certain typical characteristics. And let us take a look at what the studies have shown in terms of the effects of statins on plaque composition. And here's a summary of what we know currently. And from left to right, we know that statins, high-intensity statin treatment, not only leads to plaque volume regression, but it also stabilizes necrotic core. So we have no further increase in necrotic core by means of IVOS VH. We can see an increase in fibrous cap, so a thickening of the fibrous cap, and thus a transformation of the plaque into a more stable plaque, and also a reduction of inflammation by means of OCT. And finally, by means of NIRS, for example, in the yellow trial, we know that intensive statin treatment leads to a reduction of the lipid content. So this is a combination of favorable effects that can be achieved by means of high-intensity statin treatment, as can be demonstrated by means of different intracoronary imaging modalities. And here's an example of a patient in one of the studies that we also did in our institution. This was the IBIS-4 study, which was a study of STEMI patients. And this study assessed both non-infarct-related arteries in each patient, and all patients were treated with high-dose rosuvastatin. The on-treatment LDL was about 1.9 millimoles per liter, so slightly above actually the recommended target. And we see the two images at baseline and follow-up. We see a clear increase, also visually, but also in terms of quantitative measurements, an increase in the minimum cap thickness, which was about in the range of 30% and was also statistically significant in this pool of patients. And the subsequent analysis from the same database in these patients, we not only performed IVOS, but also OCT. So we saw that in the majority of patients, if we had TICFAs as non-infarct-related artery lesions, so lesions which were not treated as culprit lesions in the acute STEMI setting, the majority of these TICFAs actually transform to more stable phenotypes following 13 months of treatment with high-dose rosuvastatin. So we do have actually strong evidence with statins that we can achieve not only a reduction of plaque volume, but also plaque stabilization in terms of plaque morphology and composition. What about new LDL lowering drugs, which are also clinically available and also have shown significant effects on both LDL and clinical outcomes? With the PCSK9 inhibitors, with these antibodies, we have, first of all, as the first important study, the GLACOV randomized trial, which was published about 4 years ago. It was a study that included mostly patients with stable coronary disease, and it randomized patients on either statin monotherapy, so optimal statin treatment, or statin plus evolocumab once every month, and the duration of follow-up was 1.5 years. In terms of LDL reduction, the study showed that for patients treated only with a statin, the follow-up LDL was in the range of 90 milligrams per deciliter, whereas in those treated with statin plus evolocumab, the on-treatment LDL was much lower, below 30 milligrams per deciliter. And in terms of the primary endpoint of the study, it was able to show that the primary endpoint, percent atheroma volume, was significantly reduced in patients treated with a combination of statin plus Repatha, evolocumab, as compared to those treated only with a statin. And the same also held true for total atheroma volume, which was the secondary endpoint of this study. And if we look at the percent of patients who showed regression of PAV, of percent atheroma volume, so significantly more patients showed regression, 64% treated with the combination with evolocumab versus only 47% of patients treated only with a statin monotherapy. And very recently, in the recent ESC Congress, we also had the presentation of another trial, again with the same medication, the same PCSK9 inhibitor, which was evolocumab, and this was the HyGen study. It was also a randomized trial, which included STEMI patients, so this time ACS, high-risk patients, who had angiographic CAD and had elevated LDL levels with or without prior statin treatment. And these patients were randomized to either placebo on top of statin or evolocumab on top of statin. These are the results concerning LDL lowering. So we see that patients treated only with statin achieved an LDL of about 87 milligrams per deciliter, and those treated with the combination with evolocumab had an LDL, again, as in GLACOV, below 30 milligrams per deciliter. And in terms of the primary endpoint, which in this case was the minimum fibrous cap thickness by OCT, the study showed a greater increase of fibrous cap thickness, so a thickening of the cap by more than 40 micrometers with evolocumab versus about 20 micrometers with only statin. And also in terms of the lipid arc, which can also be assessed by means of OCT, here again we had a greater reduction with evolocumab of the lipid arc as compared with statin only, so that is statin plus placebo. And a very nice summary of the relation between achieved LDL or change in LDL and the change in the minimum fibrous cap thickness. Here we can see a very nice log linear relation. So the lower the achieved LDL, the greater is the increase of fibrous cap thickness, which one can safely presume that leads to a more stable plaque that is less likely to rupture and cause subsequent acute atherothrombotic events. So we do have robust evidence with both statins and non-statin agents, that is PCSK9 antibodies, in terms of both reduction of plaque volume and also stabilization of plaque composition. What is next? What can we expect in the future? Our team is actually involved in one study, which is a multimodality imaging study. It's the Pacman Amia trial, which looks at the effects of the other PCSK9 antibody, alirocumab, again, and also in patients with ACS. So the difference here to Hygien's is that we have about twice as many patients that are enrolled with a multimodality approach. So not only OCT, but a combination of OCT, IVUS, and NIRS for the two non-AFib-related arteries, so two vessels per patient. And these patients will be or have been randomized to either placebo on top of a high-dose rosuvastatin or alirocumab on top of rosuvastatin. And the follow-up here is about 1 year, so 52 weeks. The study has not been completed yet, so we expect the last patient visit actually in the next 2 weeks. So we hope that we will be able to present the results of this study in the next few months. The primary endpoint will be the change in PAV by IVUS, and the powered secondary endpoints are either NIRS-based, so change in the lipid core burden index, or OCT-based, which will be the change in minimal cup thickness. And just an example of one of the patients enrolled in this study. Again, the study is still not completed, so it is still blinded. We do not know if this patient has received alirocumab or placebo on top of statin. It's a relatively young patient with a STEMI and a baseline LDL of 4.4 millimoles per liter. This is the imaging of the circumflex artery, and we see a dramatic reduction by means of NIRS of the lipid region, the lipid pool shown here in yellow color. So we have a large amount of lipid on the top at baseline, which practically disappeared after 12 months of follow-up, as you can see by the disappearance of the yellow color. So the plaque burden also was reduced from 37% to 28% at 12-month follow-up. And in terms of OCT in this patient, in this artery, we have an increase of the cup thickness from about 300 micrometers to more than 700 micrometers. So clearly stabilization of the plaque, also in terms of the thickness of the fibrous cup. And as I said, we expect the results of this study in the next few months, and we expect and hope that it will confirm and also add to the results of the existing or the published studies in the field. Just as a closing remark, we know currently that, of course, both statins and non-statin agents have a clear favorable effect on clinical outcomes. Both categories of medications reduce the risk of subsequent major vascular events significantly, and also in a dose-dependent manner. So the greater the reduction of LDL, the greater the reduction of subsequent events. So in terms of translation of the imaging data to the clinical data, we see a clear concordance between these two findings. So we see that for both statins and PCSK9 antibodies, we have favorable effects clearly on LDL reduction. We have positive effects in terms of reduction of plaque burden. We have positive effects in terms of stabilization of plaque composition. And of course, in the last years, we also have, with both statins and PCSK9 antibodies, outcomes, positive effects on clinical outcomes. We have new medications coming up, for example, inclisiran. It will be interesting also to see what will be the effect of this medication and also future medications on both imaging data and also, of course, on clinical data. And as a final remark, we had in the past few years, we published these two consensus papers in terms of the clinical use of intracoronary imaging. These are modalities that, to be honest, started more as research tools, and they have clearly evolved in the past years as really tools that we use in the cath lab in everyday practice, and we also see more possibilities in the future to use these modalities not only to treat a lesion, to help us in stenting and optimizing, for example, the stenting result, but also in terms of assessing plaque composition and looking at presumably high-risk plaques in each of our patients. And this, for example, could be used as a marker of identifying patients who deserve even more intensive treatment, not only by lipid lowering, but also by optimization of the other risk factors. We know that for all patients, our current guidelines recommend very intensive treatment and achieving very low levels, but some patients may actually qualify for an even more aggressive approach. And these tools, these imaging tools, may be of use, of help to identify which patients will benefit clinically by using an even more aggressive treatment of these risk factors, including also LDL lowering. Thank you very much for your attention.
Thank you, Kostas, for this excellent talk you gave us. You show us all the new data concerning endovascular imaging, and especially you show us clearly the beneficial effect of statin therapy and PCSK9 therapy on plaque burden and volume and synthesis. So it was really an exciting talk. Thank you very much again. Any comments from the audience? Maybe Dr. Storey want to comment on something if he's online.
Yeah.
Hello there
Really.
again.
Hi. Yeah, it was a really beautiful talk. Lots of questions this raises. I mean, obviously, if we're going to individualize therapy based on imaging results, you'd like to see quite a high positive predictive value of these assays. And the positive predictive values for some of them, particularly CT, seem to be quite low. So do you think that's going to improve? And also, how much does the positive predictive value depend on the population that you're assessing? You know, is it different in ACS patients versus, you know, stable or asymptomatic patients?
So that's an excellent question, of course. And I think we should differentiate if we are aiming to use intracoronary imaging, which is obviously an invasive treatment modality, also associated with some cost. If we want to use it as a tool to identify patients who will deserve more aggressive systemic treatment, or those who will, for example, qualify for a local preemptive stenting. I think that we're not there yet in terms of treating stenting a lesion preemptively, so a non-obstructive lesion only based on the imaging characteristics. There are promising results, but clearly this cannot be used on a routine basis based on the evidence that we have currently. It is promising, and I think that one of the big challenges there will be to be able to use, for example, a combination of these modalities, of these tools, to be able to increase the positive predictive value and thereby identify the patients where even stenting and non-obstructive lesions may be associated with subsequent clinical benefits. So where it will be worth stenting a non-culprit lesion, for example. And the other issues are the non-invasive treatments, or the systemic treatment, where I think that clearly more evidence is needed, but I think we are going to the direction where all the pieces of evidence we have show that the highest the degree of the magnitude of risk, the greatest the risk for more intensive treatment. And I think that the use of imaging there is a valuable addition to what we can do in order to characterize more precisely the risk of an individual patient that we are seeing. So we know, for example, that all ACS patients are at high risk. For all of them, the same LDL goal is recommended, but clearly also the risk is quite heterogeneous. We know that not all patients have a subsequent event, even when they achieve extremely low LDL levels. So I think that the use of these tools will help us in the future to be more precise in identifying those where more aggressive treatment will be needed. And this does not only include, for example, LDL lowering, but also other approaches. We have some promising results from anti-inflammatory treatments in patients with CAD and also including ACS. The question is always, which of the therapies should we use? Should we put all of our patients on an extremely aggressive LDL lowering plus anti-inflammatory plus antithrombotic treatment? I think there we have some more room and more space to identify those who are at highest risk and will benefit most from the most intensive treatment or combination of anti-atherosclerotic treatments.
Thank you.
Thank you, Costa, again.
First of all, thank you for this excellent talk. And just a brief comment to the question. I think that the more you deal with the more endovascular imaging you do, you realize that if you think that you treat atheromatosis but just placing a stent in a plaque, you're definitely wrong. You realize that this is a generalized disease. So just doing a PCI is just the beginning, I think, of the treatment. You need to treat all these risk factors, and even if you see that the artery looks looks normal before and after the stent placement, you're wrong, and this is something you really need to take into account. So the question is that is it only lipid-rich plaques that you think that are going to regress if you're using statins, or this applies also to calcified plaques?
So this is a great point, first of all, regarding the need to be more holistic in our treatment. And you're absolutely right that treatment does not end with stenting. Stenting is in many patients actually the beginning of their treatment, which needs to be long-term treatment with good adherence also to all the preventive measures. Because we know, for example, from the natural history studies that half of subsequent events are triggered by non-culprit lesions. So these are the ones that will in a few years grow and result in a second or even third event. So I think, first of all, the first message should be that also to the interventional community that stenting, of course, has revolutionized the treatment of CAD, but all individuals, all physicians involved in the treatment of a CAD patient need to keep in mind this holistic approach, which extends well beyond stenting, well beyond the cath lab. And regarding the regression, it seems also from animal studies and some also clinical studies that indeed the lipid-rich plaques are the ones more likely to regress. If you have a stabilized plaque, a more fibrotic plaque, then even with a higher degree of volume or with a larger plaque, then the possibility, at least for an acute transformation, for acute rupture, seems to be low. So we seem to have two trajectories of a more stable fibrotic plaque versus a more inflamed lipid-rich plaque. But again, we should not forget that in the same patient, we may have the coexistence of both. So on the patient level, which at the end of the day is what matters, I think that we again need to keep in mind that we need to prevent the growth and promote the stabilization of those high-risk plaques, which may in the next years trigger an acute and life-threatening events.
Okay, and the last question from me, the question is for Kostas. Do you think there's any association between the composition of the plaque assessed by intravascular imaging with NIRS, for example, and the perivascular inflammation assessed by CT angiography? Do you think there is any association? Because the one option, the option of intravascular imaging is much more costly, and the other one is less costly. So in a health system like ours, that, you know, the difficulties, I think this is very crucial.
I think that is an excellent topic, and I think the discussion should also evolve more toward the direction of cost effectiveness. So we do realize that in many countries, the uptake of these modalities cannot be the same. We know that in Japan, more than 90% of PCIs are performed assisted by OCT or IVUS. This is the case in still 10% today in Europe. Some of it is also due to the increased cost, clearly. I think we have very promising data on perivascular and adiposity inflammation. We also have the group in Oxford, also with some Greek colleagues, esteemed Greek colleagues. We have shown some major findings in this respect, and this seems to be a very promising field. So if there is a direct link with intra-coronary plaque composition, and also, of course, the likelihood of subsequent events, I think that it still needs to be further explored, but I do see your point and think that if we can find a surrogate of the true intracoronary plaque composition, which can be associated with lower radiation, is non-invasive, and also has a lower cost, of course, then definitely this should also be taken into account.
Okay, thank you again. I think we have no other questions. Okay, thank you both of you for this excellent talk. It was a great pleasure seeing you again. It was really an excellent opportunity for us, all of us, to hear from you. And Dimitri?
I just hope next year to meet in person. That's it.
Okay. Let's hope so. Thank you very much again, and have a nice afternoon. Okay, bye.
Thank you very much. Thank you.
Bye.